So good morning. So welcome you all for another edition of the Online Anesthesia, a postgraduate teaching program in Zoom platform, sponsored by Akrula and hosted by A1 Logistics. Today we are having a case discussion. That session is moderated by our colleague, that is Dr. Rajesh Jeyaprakash, and it is attended by two postgraduates from Madurai Medical College, Durga and Faheema. I welcome the examiners, Dr. Jaya from JIPMER and Sudheer Babu from Global Health City, Chennai. With this case discussion, our respiratory system classes come to an end. From next week onwards, we are going to have classes on cardiovascular system. So this session is going to be moderated by Dr. Rajesh Jeyaprakash. I hand over the session to Dr. Rajesh Jeyaprakash. Please introduce the examiners and conduct this case discussion. Over to you, Dr. Rajesh.
Yes, sir. Thank you, sir. Good morning, one and all. Today we are coming to a very important session of this online teaching program. It is exclusively for the postgraduates. So a very important part of postgraduate training is clinical case discussion. So the practical point of view. So today we are going to have a discussion on thoracic anesthesia. The postgraduates who are going to participate in that are Dr. Durga and Dr. Faheema from Institute of Anaesthesiology, Madurai Medical College. And we welcome both of them. And the examiners, Dr. Jaya, Assistant Professor, Department of Anaesthesiology, JIPMER Karaikal, and Dr. Sudheer Babu, Senior Cardiac Anesthesia Consultant from Global Health City Hospital, Chennai. We welcome Jaya ma'am and Sudheer Babu sir. Now the discussion will be like first 15 minutes. There will be a case presentation by Dr. Faheema, followed by the initial first part, that is discussion on preoperative evaluation and optimization of a patient who is posted for thoracic surgery. And the second part will be intraoperative management and also postoperative management along with the complication management. So to start with, I ask Dr. Faheema, can you just start the case presentation, please? Jaya ma'am and Sudheer Babu sir, can we start the session, sir?
Yes, sir, please.
Yeah, yes, sir.
Yes, sir.
Hello, good morning, sir and ma'am. I'm Faheema, third year MD PG from Madurai Medical College. Today I'm going to present a case of bronchiectasis being posted for right upper lobectomy. Case of bronchiectasis posted for right upper lobectomy. Case details. The patient is a 56-year-old male, Mr. Krishnasamy, a resident of Madurai, belonging to lower middle class family. He came with chief complaints of cough with expectoration for 2 months and coughing of blood mixed sputum for 2 weeks. History of presenting illness. The patient had history of cough for 2 months, which was insidious in onset, productive in nature, foul smelling, mucopurulent sputum was present, which was more in early mornings, and no specific aggravating or relieving factors were elicited. He had also history of coughing of blood mixed sputum for 2 weeks, 4 episodes in the last 2 weeks. The volume was approximately 50 to 75 ml during each episode, bright red in color, foul smelling, and each time it was associated with continuous cough. Negative history. There was no history of fever or evening rise in temperature. There was no difficulty in breathing, no chest pain, palpitations, or swelling of legs and orthopnea. He had no history of bleeding manifestations like epistaxis, difficulty in swallowing, no recent voice change, no history of loss of weight or appetite, and no history of abdominal pain or other abdominal symptoms. Past history, he had history of recurrent lower respiratory tract infections. He was not a known case of hypertension or diabetes or bronchial asthma, CAD, epilepsy, or sexually transmitted diseases. There was no history suggestive of TB infection or TB contact. And he had no history of past major surgeries or no known drug allergies. Personal history. The patient was a chronic smoker for the past 25 years, smoking BD. The pack years was 12.5, that is half pack per day for the last 25 years. The patient was also alcoholic, drinking 1 to 2 times a week for the past 15 years. There was no history of illicit drug intake. The patient takes mixed diet and he had normal bowel and bladder habits. Family history, there was no significant history in the family members, no history of any TB infection or any asthmatic or allergic disorder in the family. Treatment history, for the same complaints, the patient had taken some self-medication with over-the-counter syrup and some tablets, but the condition did not improve, so he came to general medicine OP for further management. And he was a farmer by occupation, and there was no undue exposure to any chronic dust or allergens. To summarize, a 56-year-old male who was a known chronic smoker for the past 25 years, an alcoholic for the past 15 years, belonging to lower middle class family, presented with productive cough for 2 months with foul-smelling mucopollen sputum, predominantly in the morning, and 4 episodes of coughing blood mixed sputum in the past 2 weeks.
Faheema, stop here. Jaya ma'am, do you want to ask any questions here? Jaya ma'am, Sudheer sir.
Shall I share the screen? Yeah.
Yeah,
Can you
ma'am.
stop, Faheema, so it will be easy.
Good morning, ma'am.
Good morning, Faheema. Yeah, it's a very nice presentation. Can you tell me the positive and negative findings in our case?
Positive findings was the history with which the patient presented was cough and hemoptysis. And for the past history, the patient was a chronic smoker for the past 25 years. He's coming from a lower socioeconomical background. He may be more prone to infections. He was also a chronic alcoholic.
Okay, from the history, what you are expecting? Which system will be involved?
From the history, I suspect that probably the respiratory system might be involved.
How you come to this conclusion?
Because he has cough and hemoptysis. There could be only 2 probable systems, that is the respiratory and the cardiovascular system. If it had, or it can also be a GIT. If it is cardiovascular system, he might have had a history of exertional dyspnea or a chest pain or swelling of legs, orthopnea, PND, but he is not having any of these symptoms. And in case of GIT, if he is having, he will be having hematemesis rather than hemoptysis. And in this case, he is coughing out bright red colored sputum. But if it was hematemesis, it could be dark red in color and associated with the cough, food particles or nausea and vomiting. And none of these are there. So we're ruling out other 2 systems. We can guess that it could be respiratory system that is involved in this patient.
Okay. From color of the sputum, what we can infer?
From the color of sputum, in bacterial infections, it will be yellowish or greenish sputum. In Klebsiella infections, recurrent jelly sputum will be seen. Or if it is any cancer or CA associated, serous sputum will be seen as in alveolar cell CA of lung. In amoebic liver abscess and lung abscess, anchovy sauce will be found.
Okay, what about in pulmonary edema?
Pulmonary edema, pink, frothy, thin, serous secretions will be seen.
Okay, so we know that in this case, mostly the respiratory system is involved. Okay, so shall we go for the examination?
Okay.
Sudheer sir, you want to ask anything, sir? Sudheer sir?
No, sir, fine. We can continue.
Okay. Faheema, we can continue.
Okay, sir. On physical examination, general examination, the patient was moderately built and nourished. His weight was around 65 kg and height was 170 centimeters. The patient was conscious oriented, afebrile. There was no pallor, cyanosis, or pedal edema. Grade 2 pan-digital clubbing was seen, and there was no generalized lymphadenopathy. Vitals, his pulse rate was 86 per minute, regular in rhythm, normal in volume, with no specific character, and all peripheral pulses were felt equally, and there was no radiofemoral delay or vessel wall thickening. The respiratory rate was 14 per minute, which was regular abdominal thoracic in pattern. Temperature was 36.5 degrees Celsius in the right axilla. The blood pressure was 120 by 70 millimeters of mercury measured in the right upper limb in the lying posture, and the saturation in room air was 96%. Airway examination. Examination of the oral cavity revealed adequate mouth opening with interincisor distance of more than 3 finger breadth. The dentition tongue palate was normal and Mallampati grade was grade 2. Examination of the nasal cavity. The external nerves were normal. There was no obvious deformity of the nasal bridge or no deviated nasal septum. The nasal patency test showed that both nostrils appear equally patent. Examination of the mandibular space. The gyromental distance was 6 centimeters and hyomental distance was 5 centimeters. Neck movements, flexion and extension was normal. Examination of the upper respiratory system revealed that there was no subtle deviation or sinus tenderness or tonsillar enlargement. Examination of the lower respiratory system. On inspection, the trachea appeared to be in midline. Chest wall shape was normal and bilaterally symmetrical. Both sides moved equally with respiration. Apex beat was seen in the left fifth intercostal space, half-inch medial to the midclavicular line. There were no scars, sinuses, or dilated veins over the chest wall. On palpation, trachea appears to be in midline. And on palpating the apical impulse, it was felt in the left fifth intercostal space, half-inch medial to the midclavicular line. Chest dimensions. The transverse diameter was 27 centimeters and the anteroposterior diameter was 18 centimeters. On palpation, chest expansion was adequate. The chest circumference showed that during inspiration it was 74 centimeters and during expiration it was 70 centimeters. There was no tenderness over the chest wall. We had images showing the expansion of the upper thorax, the posterior thorax, and the anterior thorax. Tactile primitus was increased in the supraclavicular and infraclavicular regions of the right hemithorax, whereas in all other areas it was normal. There were no palpable added sounds. On percussion, we found a dull note in the supraclavicular and infraclavicular regions of the right hemithorax with resonant notes heard in all other areas. It shows the percussion of the suprascapular and the interscapular region. On auscultation, the coarse mid-inspiratory crackles could be heard in the right hemithorax, in the supraclavicular and mammary regions predominantly, whereas in all other areas, normal vesicular breath sounds were heard. Bronchophony was also heard in the right intraclavicular space. Vocal resonance was increased in the right hemithorax with increased in especially in the intraclavicular and mammary areas of the right hemithorax, whereas it was normal elsewhere. Examination of other systems, cardiovascular system, abdomen, and CNS was within normal limits. To summarize, a 56-year-old male, a known chronic smoker for the past 25 years, an alcoholic for the past 15 years, belonging to a lower middle class family, presenting with productive cough for 2 months with foul-smelling mucopollen sputum predominantly in the morning, with 4 episodes of hemoptysis in the past 2 weeks. On general examination, he had pan-digital clubbing with systemic examination revealing positive findings predominantly in the right supraclavicular and infraclavicular regions. So the provisional diagnosis is chronic obstructive pulmonary disease with suppurative lung disease, probably bronchiectasis, with the probable location being the right upper lobe.
Good presentation, Faheema. In the examination, you told trachea is midline. Why do we have to examine the trachea? Faheema?
Yes, ma'am. We have to examine the trachea to check if there is any tracheal deviation. Tracheal deviation can be seen to the same side in case of collapse, or can be pushed to the opposite side when there is contralateral effusion or any mass pushing the trachea to the opposite side.
Okay. What happened in fibrosis?
In fibrosis, trachea will be pulled to the same side because of volume loss.
Okay. In percussion, you told dull notes, correct? No.
Yes, ma'am.
Dull notes are seen in which condition?
Dull note will be seen in effusions, pleural effusion, empyema, fibrosis.
Fibrosis, dull note. Okay. Okay. You told the provisional diagnosis suppurative lung disease. Correct? No. What are the suppurative lung disease? You know.
Suppurative lung disease may be bronchiectasis, a lung abscess, empyema, maybe loculated abscess.
Okay. So how you differentiate between empyema and the bronchiectasis?
In case of bronchiectasis is the irreversible dilatation of the bronchioles distal to the respiratory bronchioles, whereas empyema will be collection of pus between the pleural layers.
That is
So
after only after investigation you will be able to identify, correct? With the examination and history, how you identify?
Sputum production, the coughing or sputum production will be predominantly early in the morning in case of bronchiectasis, whereas diurnal variation will not be seen in case of empyema. And there will be a chest wall tenderness in empyema on palpation. In duration of chest wall tenderness, redness may be seen in empyema. In bronchiectasis, these findings will not be present.
And also they have systemic inflammatory signs like fever. All those things will be there with the empyema because that is an infectious cause, correct? Okay. So mostly the patient is middle-aged patients will be having bronchiectasis. If it is a young patient, they may be cystic fibrosis, may be the cause for bronchiectasis. Okay. And chronic cough and diurnal variation will be more towards the bronchiectasis. And as because you told so many negative histories, correct? No. The PND and orthopnea will rule out the cardiac cause, and fever and tachycardia will rule out any infectious cause of respiratory illness. And it is a progressive illness. That's what you told. Over the 2 months it is there, and there is no dyspnea. That shows it is not a cardiac cause. Okay. So what is the bronchiectasis?
Bronchiectasis is defined as irreversible dilatation of airways distal to the respiratory bronchioles. That is predominantly involving the respiratory bronchioles, alveoli, and the alveolar duct.
Okay, that is mid-respiratory tract. Correct? No.
Yes.
Okay, it is a pathological condition. In clinically, how it is called? This condition is called clinically. We call it as chronic suppurative lung disease. Correct. So how you define chronic suppurative lung disease for clinical definition?
Sputum production on most days for 3 months for more in 2 consecutive years. Or
yeah, it should be the patient should have sputum production for at least 3 months duration for 2 consecutive years. That's what it's called clinical definition for chronic obstructive lung disease. So chronic obstructive lung disease or COPD, that is include chronic bronchitis emphysema. Chronic bronchitis is the clinical condition, clinically defined condition. Emphysema is the pathological condition. Okay. And bronchitis is irreversible dilatation, not the reversible like asthma. Okay. So color of the sputum already we have discussed. And how we differentiate hemoptysis and hematemesis already you have told. Correct. So what are the causes of hemoptysis?
causes
Cause of hemoptysis includes lung cancer, pulmonary AV fistula, cavitary lesion, suppurative lung diseases. Norris causes.
Okay, serious causes?
Serious causes are acute left ventricular failure, aortic aneurysm rupture.
Most common cause? Most common disease we see?
Mitral stenosis, severe pulmonary hypertension.
Yeah, okay. So what is dyspnea? And can you grade the dyspnea of respiratory disease?
Dyspnea is the undue awareness of one's own breathing. It can be graded according to cardiac classification, NIHA classification, and respiratory causes with the MMRC. I will mention both the two. NIHA.
MMRC you tell. NIHA is for cardiac.
Cardiac case. MMRC grade, there are 5 grades. Grade 0, dyspnea with strenuous exercise. Grade 1 is dyspnea with patients walking uphill. Grade 2 with dyspnea with patients walking at the same pace of the same age group. Grade 3, patients are too breathless to walk greater than 100 yards. Grade 4, too breathless to leave the house.
Okay. So, he told clubbing. She examined the clubbing. What is clubbing?
Clubbing is a selective bulbous enlargement of the distal phalanx of the digits due to increased soft tissue
Proliferation. Okay. So, what are the grades of clubbing?
There are 4 grades of clubbing, ma'am. Grade 1, arbitration of the angle. Grade 2, parrot beak appearance. Grade 3, drumstick appearance. And grade 4, hypertrophic osteoarthropathy.
Okay. What are the causes?
Causes include both respiratory and pulmonary causes. Respiratory and cardiac causes. Respiratory causes include lung CA, suppurative lung diseases, interstitial lung diseases, TB, etc.
Okay. Cardiac?
Cardiac causes include cyanotic heart disease, left atrial myxoma, Eisenmenger syndrome, infective endocarditis.
Okay. So, how you investigate this patient? Fatima? You want to answer, Durga?
We'll proceed with the routine investigations. Complete blood count. With complete blood count to rule out infection, active infection, inactive infection. We'll see routinely see the blood sugar level, RFT, serum electrolytes, and liver function test. Added to that, we, as it is an RS case, we'll see chest X-ray. In chest X-ray, we can see tram track appearance.
In general investigation, why we have to look at the LFT? You told LFT, what do you expect in this case? In case of
bronchiectasis, there will be hypogammaglobulinemia. So proteins and enzymes can hypoproteinemia.
Okay. In HP, what do you expect in HP?
COPD, generally there will be polycythemia due to increased erythropoietin, chronic hypoxia leading to increased erythropoietin production.
So if the HP is normal, that shows that the patient may have an anemia also. Okay. Because we are expecting the polycythemia. Okay. Then in chest X-ray.
Chest X-ray, we can see a tram track appearance of the bronchioles.
Okay.
In CT chest, HRCT is the most diagnostic tool to identify bronchiectasis. You can see signet ring sign, increased bronchial wall thickening.
Okay.
Clean bud appearance in CT chest.
That is because of
dilated bronchioles.
Dilated bronchioles will have the tram track appearance. Okay. The tree in bud appearance because of the insipid secretions in the dilated bronchiole. Okay. So
we can also see ECG and echocardiogram. In ECG, we can see RAD, the right axis deviation. P pulmonale can be seen in case of COPD.
That shows what? P pulmonale shows what?
Carpal right ventricle dysfunction may be present. So we can further proceed with echocardiogram to see right ventricular dysfunction and to also measure pulmonary artery pressure. If there is any associated pulmonary hypertension.
Okay. In echo, what do you want to assess?
Echo, we can see RV dysfunction and pulmonary artery pressure.
That is to rule out carpal. Okay. Okay. This is the X-ray of that patient. X-ray and CT of that patient. The X-ray, the CT shows the right upper lobe bronchiectasis and the X-ray shows the tram track appearance. Okay. So, investigation, we'll look at the general investigation, and this specifically we look for the X-ray and HRCT, as already you told. What are the bedside pulmonary tensions you know?
Coming to the bedside pulmonary function test, we have 2 categories: function test to test vital capacity and test for vital capacity and dynamic function. First one, the test for vital capacity. We have Sabras is a breath holding test, and Sabras is a single breath count test. Test to measure vital capacity and dynamic function.
We explain each test, no, and how you interfere, interpretation of that test.
Sabras is breath holding test and the single breath count test is used for measuring the vital capacity. If the patient is asked to take a deep inspiration and hold the breath and then count numbers for each number and count numbers. If the patient is able to count more than 35, it means that his vital capacity is more than 3.5 liters. And if he counts less than 15 numbers, it implies that his vital capacity is less than 2 liters, which means that the patient is at higher risk. The same is for breath holding test. We ask the patient to take a deep inspiration and then ask him to hold the breath for how much time he can. If he can hold the breath for more than 40 seconds, it means that he has a good pulmonary reserve. And the next category of test is test for testing the vital capacity.
What is the time, normal timings, and how much you accept for a low breath time, breath holding time?
Breath holding time, if it is more than 30 seconds, it implies that his vital capacity is more than 3.5 liters. For low lobectomy, it is advised that at least 2 liters of vital capacity should be more than 2.5 liters.
More than 2 liters is enough. Okay.
The breath holding time is less than 15 seconds. Okay, the patients are at high risk for lobectomy.
Okay.
Coming to the next test, single breath count test. The patient is asked to count from number 1, and the time is measured. If the single breath count
is it the time or the count? How many
count is measured. The patient is able to count greater than 30. The patient has a good vital capacity, and if it is less than 15, it has a poor outcome.
The next group of tests is tests for vital capacity and dynamic. And the test for vital capacity and dynamic function together. And in this category, we have the Snyder's match blowing test, Greene and Gurusanthiya's whistle blowing test, DeBono's whistle peak, Wright's peak spirometer. In the first test, that is the Snyder's match blowing test. It is used to find the maximum breathing capacity of the patient. In this, the patient will be asked to sit in a quiet room with no air movement, and his chin will be supported, and there will be a candle kept at the same line as his chin, and the patient will be asked to blow with his mouth wide open. If he is able to blow the candle at a distance of 9 inches from it, it means that he has a good maximum breathing capacity of more than 150 liters per minute. If it is less than 3, he is able to blow only within 3 inches. It means that he has a poor maximum breathing capacity of less than 40 liters per minute. The next test is
cough test. We are measuring the ability, strength, effectiveness, and productive nature of the cough. Inactive cough refers to if FVC less than 20 ml per kg, FEV1 less than 15 ml per kg, PEFR less than 200 liters per minute. Next is the forced expiratory time.
Okay.
In the forced expiratory time, less than 3 seconds implies severe expiratory outflow obstruction. Greater than 3 seconds implies the expiratory outflow obstruction.
Okay. Okay, what are the tests for cardiopulmonary reserve?
We have 3 tests: 6-minute walk test, shuttle test, and stair climbing test. In stair climbing test, if the patient is able to climb greater than 5 flights of stairs, VO2 max can be calculated at greater than 30 ml per kg per minute, and patients have very good outcome, post-op outcome. The patient is not able to climb less than 2 flights of stairs. VO2 max is less than 15 ml per kg per minute, having a poor outcome. In shuttle walk test, patient is asked to walk shuttle 10 meters apart. If the patient is less than 25, able to complete less than 25 shuttles, VO2 max is less than 15 ml per kg per minute.
That is higher risk for
Higher risk
thoracic
for a
procedure.
thoracic procedure.
Okay.
And 6-minute walk test. If the patient is unable to walk less than 450 meters in 6 minutes, patient has a VO2 max less than 15 ml per kg per minute, having a poor respiratory outcome.
Okay. So these are the tests you already told, and this patient had, when they did 6-minute walk test, the patient could be able to walk 462 meters and can climb 3 flights of stairs and can walk 450 meters. So what will be the VO2 for this patient?
VO2 may be around just in the borderline.
Can walk 462, no? So it will be more than 415 ml per kg. Correct?
Yes.
Okay. So what other tests do you do? You all did all the pulmonary function tests, bedside pulmonary function tests. What else do you do? These are all subjective, no? Objectively, what test do you do?
Objectively, we have to do spirometry. In spirometry, we see the FEV1, that is the force expiratory.
Spirometry is to assess what?
To find the dynamic function of the lung.
Respiratory mechanics.
Mechanics.
Okay.
Mechanics. In that, we elicit mainly 4 tests. That is the FEV1 or the force expiratory volume in the first second, and FEV1 by FBC ratio. That is a ratio of FEV1 to forced vital capacity. Then forced mid expiratory flow, that is 25 to 75% of the expiratory flow. In this patient, we found that the FEV1 was reduced to around 65%, and the FVC, that is the forced vital capacity, remained normal to about 95% of the predicted value. So, on the whole, the ratio of FEV1 to FVC was reduced to less than 65, and which implies that he has a mild obstructive disease. And also, the forced mid expiratory flow was reduced to 55%, which also implies that the patient has a mild obstructive disease.
Okay, mid expiratory flow rate, why we are sharing it?
It is the mid expiratory flow is the earliest indicator of smaller airway diseases. So we try to assess the person.
Okay, FE1 at 6 is what? At 6. FE1 at 6 seconds. That shows that independent of the patient's effort. Okay. That is when patient is not able to follow your comments, that will help us to assess the pulmonary function test. Okay. So that all you looked at the respiratory mechanics. Any other test you want to do?
Other tests like ABG.
Yeah, ABG.
Arterial blood gases, in pulse oximetry, respiratory rate are the other common tests which can be done.
Okay. If the FE1 and FVC are less, okay, then what else we can do it? And 6-minute walk test, all the bedside, like your pulmonary function tests are showing very low risk. So what else? What other tests we can do it?
Parenchymal functioning has to be tested.
Parenchymal function you can assess by your PaO2, PeCO2, no? Aminic acid or diffusion capacity. Okay. Okay. What for cardiopulmonary exercise test, you know? That is an expensive test which you can assess the cardiopulmonary VO2 max. When you are not able to assess the by your start clamping because of your arthritis or any other thing, then we can go for the cardiopulmonary exercise test. Okay. So this is what the patient's pulmonary function test. You told this is a obstructive, mild obstructive disease. Okay. ABG showed?
ABG showed that pH is 7.36 and PO2 is slightly normal, that is 78, and PaCO2 is 55. Bicarbonate level was also increased. This implies that the patient is in a state of chronic compensated respiratory acidosis.
What is the cutoff value for respiratory for thoracotomy in ABG?
PaCO2 more than 50 means the patient is at a high risk for
High risk
lung
for,
surgery.
okay. This patient is more than 50, correct? No? So, how do you improve this one?
We have to exercises, deep breathing exercises, chest physiotherapy, in-situ spirometry, postural drainage have to be done preoperatively.
Okay. Okay, we'll go for the other one. Sorry. How you optimize the patient, this patient preoperative?
Preoperatively, the first point is
Durga, you are not audible. Durga?
Sir?
You are not audible.
Am I audible now?
Yeah, yes.
Preoperatively, the first is cessation of smoking. Ask the patient to stop smoking. Next is the bronchodilator therapy with inhaled corticosteroids and beta-2 agonist. Systemic and air humidity, systemic hydration and air hydration is loosen up secretion. Remove the excess secretion by giving mucolytic therapy and expectorants. Adequate chest physiotherapy, postural drainage, and coughing to bring out the secretions.
Okay.
Sputum production less than 40 ml may be ideal for before posting for the surgery.
Okay. So you told first is cessation of smoking. What is the benefit of this over time?
Over time.
And what is the ideal time for taking up the case?
Yeah, but in 12 to 24 hours, there is a decrease in carbon monoxide and nicotine levels in the blood. In 40 to 74 hours, there is a decrease in carboxyhemoglobin. In 72 hours to 1 week, there is increased mucociliary function. In 1 week to 2 weeks, there is decreased sputum production. In 2 to 4 weeks, there is increase in PFT. 4 to 6 weeks, there is an increase in immune function and metabolism. In 6 to 8 weeks, there is overall improvement in morbidity and mortality of the patient.
So what is the minimum time you want preoperatively?
6 to 8 weeks.
At least minimum of 4 weeks. Okay, and then only the improvement in mucociliary clearance and immunology is that minimum 4 weeks in case of CA. We can't wait for more than 4 weeks. Okay. You told bronchodilator therapy, correct? No. So when you know that your bronchodilator is acting maximum, okay, this is enough for this patient.
You can measure pre-bronchodilator therapy FEV1 compared to the post-bronchodilator therapy FEV1. If there is an improvement in exercise tolerance with the elevation of clinical symptoms, we can.
How much improvement you expect and is expected to say that there is patient is bronchodilator responsive?
10 to 15%.
That is 12%. Okay. Okay. This patient is right upper lobe, correct? So what is the position for postural drainage?
For postural drainage, we can place the patient in erect position or in semi-recumbent position so that the secretions come up to the tracheobronchiality and patient can cough out the excess sputum.
Okay. For upper lobe, it is the erect proper push. Okay. So what is when you take up this case for surgery?
Surgery, after adequate optimization with
bronchodilator. Say that is adequate.
With adequate bronchodilator therapy, VO2 sputum production less than 40 ml.
Okay.
If improvement in FEV1 function, FEV1 greater than 8.
Okay. This we will have to expect for lobectomy, the patient should have more than CO2 of 15 ml per kg per minute. That will assess by this one. These are the methods. And PFT also should be more than 75% of the expected. Okay, FE1 should be more than 75% of the expected. Then it is for pneumonectomy. For lobectomy, at least 50 to 75% of FEV1. Okay. So how you stratify risk stratification for this patient?
Revised cardiac index. 6 points. 6 points in revised cardiac index score. Each carries 1 point. History of ischemic cardiac disease, history of CVA, history of congestive cardiac failure, patients diabetic patients receiving insulin, renal creatinine greater than 2.
Okay, what is the revised thoracic RCRA?
Thoracic surgery, the first 3 points as 1.5 points of 1.5. Pneumonectomy, history of IHD, history of CVA, and renal function greater than creatinine greater than 2.
Okay, and this shows that the major cardiac events are more than, if the point is more than 3, it is 15%. Any other score you know for pulmonary, postoperative pulmonary complications? There is another score is ARISCAT. Okay, that depends on the age and preoperative saturation, respiratory infection, preoperative anemia, and duration of the surgery. We can calculate the score and we can calculate what is the expected pulmonary complication. Okay, so we optimize the patient. Next, Sudheer sir, can you take over?
Actually, madam, before moving on to the next session of
yes, sir.
So now we have come to a discussion that the patient is posted for
right upper lobectomy.
Lobectomy. Okay.
Yeah.
For the PG shaker, it is not like always the exam is going towards only lobectomy.
Yeah.
Sometimes it may be posted for some other discussions also. So as a postgraduate, from here you should be ready to tackle any type of surgeries, including this patient can be posted for some laparoscopic surgeries or thoracoscopic surgeries or something like that. So as a postgraduate, we should be ready to tackle that type of questions also. But now we are restricting our discussion only towards patient getting posted for thoracic surgery. So Sudheer Babu will continue from here about the intraoperative and postoperative management, and the patient is posted for thoracic surgery. Sudheer sir, now you can.
Okay, sir. 1 minute, I'll share my.
Before going that, as because you told that patient may be posted for other surgeries, so how you grade the COPD? You know, the stratification.
Grading of COPD can be by goals criteria.
Yeah.
Global Initiative for COPD. After 2020 guidelines, it is divided. COPD patients are classified into patients at risk with mild risk, moderate or severe risk, or very severe risk. Patients at risk for COPD are patients who have chronic cough or sputum production, but their FEV1 and FEV1 to FVC ratio will be normal. In the mild category, we have patients with the same symptoms, and the FEV1 to FVC ratio will be less than 0.7, but the FEV1 is still above around 80%. In moderate category, they have chronic cough and sputum production, and the ratio is still less than 0.7, but their FEV1 comes down to 50% to 80%. In a very severe group, they start having signs of respiratory failure along with the cough production, and the ratio of FEV1 to FVC is still less than 0.7, and FEV1 will be below 50, between 30 to 50. In the very severe group, they have overt respiratory failure with the low ratio, and also the FEV1 will be less than 30%.
Okay, thanks.
Very nice presentation. Like, is it? Is my means what are the screen is visible?
Yes, sir. Yes, sir. Visible, sir.
Yeah. So, first question is, how do you plan anesthesia for this patient, and what are the gadgets to be ready before taking for this patient in the ward?
For this patient, after adequate preoperative assessment and optimization, The patient will be posted for right upper lobectomy. The plan for anesthesia is general anesthesia with controlled ventilation with thoracic epidural for the intraoperative and postoperative emergencies.
Okay. Means like what is the advantage of epidural? Means like anyway, like we are planning for lung isolation is definitely required. So why can't we go ahead only with GA? What is the additional advantage of epidural in this patient?
For intraoperatively, first of all, the placement of epidural can help in the intraoperative pain management, and postoperatively also adequate analgesia can be given to cover more number of segments compared to other nerve blocks with a smaller dose of local anesthetic or opioids. And also, a good thoracic epidural analgesia can improve the lung function, improve the diaphragmatic movements, and patient will breathe comfortably if he has no pain. So postoperative pulmonary complications can be reduced.
So when you will put the epidural, like after induction or before induction, which one is like ideally preferred?
Before induction of anesthesia.
Okay. So and make sure that before taking the patient, always review the radiological images, especially the CT scan, X-ray pulse, especially for the CT scans to rule out any like distorted, especially in the COPD patients, there may be a distorted tracheobronchial anatomy. So you may face difficulty while placing the, while isolating the lung also. Okay. So what are the, just for completion's sake, advantages of volatile anesthetics, advantages is decreases the inflammatory response to the acute lung injury, but it has a disadvantage, like it may attenuate the HPV response and increases the shunt. Okay. So, like, suppose why can't we, like, is it possible to take the patient without general anesthesia, with only regional? Is it possible?
One lung, one ventilation cannot be achieved with only regional.
Okay,
So,
but suppose if in case of high-risk patients, like only just some empyema drainage or some pleural effusion drainage, is it possible? And the patient is high risk, and anyway we have to take to improve the like his whatever the saturation and lung function. So is it possible? So there is something called non-intubated video-assisted thoracic surgery. So it is an alternative to GA, especially in high-risk patients. So this, like with conscious sedation combined with regional anesthesia, we can do. Only thing is we have to take spontaneous ventilation, but the complications like patient will be like intolerance of the patient and disruption of the surgical field from the mediastinal and diaphragm motion can happen, and at any time we have to convert to the GA. Okay. So what monitoring you plan for this patient?
Apart from routine monitoring such as NIBP, pulse oximetry, ECG, we have to place capnometry to measure the continuous measurement of ETCO2. So, arterial line to detect severe hypertension and to take ABG. The next one is to the advanced monitors such as PA catheters and DE can be used. PA catheters may be less reliable as we cannot predict whether it lies in dependent or non-dependent lung to detect LV preload. TE monitors continuous real-time function of myocardium, but it is difficult to place in lateral position. TE can be used in special situations like hemodynamic instability, pericardial effusion, cardiac involvement of the tumor, pulmonary endarterectomy.
See, all those things are like theoretically they might have given in the textbook, but actually if you come to the practically, PA catheter and TE rarely we use for the thoracic surgeries, but PA catheter other than the standard ASA monitor, but the limitations of ESC, what are the limitations of ECG in a patient posted for thoracotomy? See, we cannot place the leads, especially the V5 lead. Suppose if the patient is undergoing left thoracotomy, we cannot place it there, right? So we have to place the ECG lead also in a means like into the non-operative side, right? So then what happens? Like so the means sensitivity of detecting ischemia is less. Okay. And another thing is what you mentioned, temperature monitoring is also one of the most important things, because the heavy thorax, like it will be exposed for so many hours. So you definitely Suppose if you are planning for the early on-table extubation, even you have to maintain the temperature also, right? So coming to the PA catheter, so two disadvantages for the PA catheter is normally PA catheter should sit in the zone 3 because it has a more perfusion, right? Suppose if the patient is on the right side of the lung. Suppose if the patient is operated on the right side, like your patient, like posted, so the right lung is collapsed. So you won't be getting the correct appropriate use of the LVEDC. Okay. So another thing is you will be applying the PEEP also, right? So all the PEEP also, it will be affecting your PCWP value. So these are the limitations. And also TEE may be required if the patient is very hemodynamically unstable. And one more common indication where the TEE can mean everything is okay, but the patient is having hypoxemia. Then in that situation, you can see whether any right to left shunt is there. So because undetected TFO or something, so that we can, for that case, actually TE can be useful. So cardiac output monitoring also, maybe esophageal Doppler monitoring can be helpful versus the cardiac output, but these are all like some, and only if the patient is having specific cardiac, because if any cardiac indication, already cardiac patient means maybe we can consider. Otherwise, the remaining all the standard monitors we can use. Okay. So how do you induce this patient? Sorry, you are not audible.
Hello, sir.
Faheema, yeah.
Sir, for inducing this patient, first the patient is kept in a secretion retaining position to avoid spillage of secretions into the other lung or into the healthy lobes of the same lung. And then the patient is induced with rapid sequence induction, sir. Preferentially with IV inhalation, IV anesthetic agents like propofol.
Okay. So which size peripheral line, IV line you have to put, right? So size and which limb preferably, like you have to put, because you are keeping in the lateral position, right? So it should not it should not be obstructing your IV fluids, everything, right? So ideally, like the IV line can be inserted in the non-dependent limb and avoid antecubital fossa because it will be like a little bending, right? So it should not obstruct your IV fluids. And also, in case if the patient is having anterior mediastinal mass or something, you can consider putting in the lower limb. Okay. All those things you have to tell, especially in the exam. Okay. Regional anesthesia prior to the induction with mild sedation. And what is the advantage of pre-oxygenation other than the regular, especially in thoracotomy patients? So normally any patient, just to build up the FRC, will be pre-oxygenating the patient. But additional advantage of pre-oxygenation in thoracotomy patients.
100% oxygen can lead to earlier collapses of the non-ventilated lung.
Yeah, because it causes the denitrogenation, and because nitrogen is poorly soluble, it may delay the collapse of the lung. So this will be helpful, pre-oxygenation, it will be helpful in the early collapse of the lung. So and arterial line, you can place the dependent arm to prevent the damping, and induction, like depending on that, you can use fentanyl, propofol, all those things, inhalational agents. Like, and also suppose if the patient is planned for sometimes, just they want to do bronchoscopy before intubating the patient itself, they want to do diagnostic bronchoscopy. So how you will plan? Because diagnostic bronchoscopy means usually they will do the fiber optic bronchoscopy, right? So you induce the patient. So how you will plan for, or sometimes rigid also, sometimes they may do. Okay, how you will plan? Rigid means anyway they will pass with apneic oxygenation. We have to maintain the saturation. Suppose if it is fiber optic means either we can put LMA, and through the LMA they can pass the fiber optic bronchoscope, or even with apneic oxygen normally they can do the with the help of the airway, through the airway they can pass the fiber optic bronchoscope, and then they can do the diagnostic bronchoscopy, and then later they can then we can intubate with the whatever the DLT or bronchial blocker. Okay. So tell me various methods of lung isolation and its advantages and disadvantages. So for this patient, like height of the patient, I didn't.
170 centimeters.
Okay. So how you will plan the lung isolation for this patient?
For lung isolation, we can use either a double lumen tube or a bronchial blocker, or other two options are single lumen tube advanced into the bronchus or an endobronchial tube. So, in case of double lumen tube for this patient, since he is 170 centimeters in height, 39 or 41 French left-sided DLT will be appropriate. So, advantages of DLT are that it is easy to place using a blind method. Um, Separate access to each lung is easier to achieve. We can give suctioning or CPAP or administration drugs to each lung separately, and it's easy to alternate between the two lungs during the intraoperative period. And the disadvantages are that in case of any distorted upper airway or in case where we need taser-tracheal intubation and the WM tubes cannot be used, and for post-op ventilation, we have to change on to a single-limit tube. And the next option is bronchial blockers. The advantage of bronchial blocker is that in case of nasotracheal intubation or distorted anatomy or pediatric age group, bronchial blockers can be used, whereas the WM tubes cannot be used. And but the disadvantage is that we need a bronchoscopic guidance to place the bronchial blocker. And there is access to two lungs is. If a lung is blocked, the access to that lung becomes less, and we cannot switch over from one lung to other easily during one lung ventilation. The next one is a single lumen tube. Single lumen tube can be advanced into one bronchus, but the same way, the access to the other lung or ventilation of switching between ventilations will be difficult. This is true for endobronchial bronchus also.
And also mainly the endobronchial or endotracheal rarely we use, especially only maybe in case of sometimes in pediatrics, but most of the time we cannot do bronchoscopy or suctioning or CPAP to the isolated lung. Okay. So, what is the optimum method to choose the DLT size?
For choosing the WM tubes, we can.
Can you see my screen, right?
Yes, sir. It is visible.
Yeah. Okay.
The size selection can be done by preformed predictor formulae or by imaging methods. In case of the formulae, we have Benmoff and Broadis predictors, which is in which the size is selected according to the height and gender of the patient. And in imaging techniques, we can by using chest X-ray we can find the tracheal diameter, and we can estimate the size of the left main bronchus. For example, the left main bronchus is approximately 0.68 times the tracheal width. That is from chest X-ray. And from other imaging like CT, from CT scans, superimposition of the DLT over the patient's CT film can be done to approximately guess the size of the DLT.
Yeah, very good. So, so there is something called from the chest X-ray PA view, we can measure the diameter of the trachea and clavicular region, and accordingly some recommended DLT size is there. But actually the disadvantage of this is based on this, suppose if we follow this, there is a 90% chance like we'll be overestimating the size, because this is not much applicable for our Asian population. Okay. So this is basically for the Western population. So there is a possibility like we may oversize the tube. Okay. So the best method is so based on your height, based on the height of the patient, and also along with that measuring the tracheal diameter, combinedly we can based on that we can choose the appropriate DLT size. Okay. So this is something like a female 160 centimeters or male 170 centimeters. Based on that we can choose the diameter DLT. So there is something called which is like a new advance, like not much new advance, but utility of the tracheal ultrasound also. So nowadays they are saying like along with the height of the patient, height and sex of the patient, if you use tracheal ultrasound. So this is the optimum method to size the DLT. Okay. So the tracheal ultrasound probe we have to place perpendicularly at the neck, suprasternal nose, and based on that we can actually this gives better than from compared to the measuring of the tracheal diameter. Okay. And also another thing is, yeah. So, and most important thing is, along with the sizes of the DLT, you should have some idea about the fiber optic bronchoscope also, because which size fiber optic bronchoscope, especially only pediatric bronchoscope, will be able to pass to the DLT. Okay. So that what are the available sizes used also, you should have some idea. Okay. Mostly 3.5 mm size is the one which we use. Okay. So then just what are the indications of DLT? So there is no, previously they used to say like
is an absolute indication. Okay. So otherwise, just if you go through that, most of the times, like we prefer left-sided DLT because the margin of safety is good for the left-sided DLT. So why the margin of safety is more good for the left-side DLT?
As the right upper bronchus origins 1 to 2 centimeters from the carina, the margin of safety is high in left-sided DLTs.
Okay. So what is the contraindication for only contraindication for left-sided DLT?
Surgeries involving the left mainstem bronchus like left pneumonectomy, left-sided lung transplantation, or any disruption of the left main bronchus in case of traumatic injury to the left main bronchus, or any tumor compressing upon the left main bronchus. So in these conditions, we have to use right-sided DLT.
Suppose you don't have right-sided correct size DLT most in your hospital, suppose, and the patient is posted for left pneumonectomy. So won't you place left DLT in that patient? Suppose if you have to place left DLT. Suppose in that case, if the patient is posted for pneumonectomy, what you will do? Do you place blocker for pneumonectomy? Because ideally, practically speaking, all these blockers, everything are good, but thing is like there is a high possibility of dislodgement. So, and especially for the pneumonectomy, all those things, better to should have good lung isolation, even for lobectomy or pneumonectomy. Blockers, it will be useful for like process like decortication or something, no? It will be good, even bullectomy, all those cases. So suppose if you are placing the left-sided DLT, it's not an absolute contraindication for left pneumonectomy. Only thing is just before the clamping, stapling, you have to just pull out your left DLT so that it won't be included in your stapling. Okay. So otherwise, it's left-sided DLT is not a contraindication for left pneumonectomy. Okay. Ideally, if right DLT is there, means better to put right DLT. Only thing is some amount of technical expertise is required if at all if you are using the right-sided DLT. Okay. So these are the indications of right-sided DLT. Mainly, if there is any distorted anatomy of the left mainstem bronchus, then right-sided DLT can be placed. Only contraindication is sometimes the right upper lobe bronchus is some anomaly, like it may be arising just at the level of tracheal carina only. So in those cases, you may not be able to put ventilate the right upper lobe bronchus. So in those cases, we cannot put the right-sided DLT. So tell me various methods to insert the DLT. What is the success rate if you use only blind method?
DLT can be inserted by either blind technique or using fiber optic guidance, sir.
Okay.
In blind method, we have the method of insertion is first we have to hold the DLT in such a way that the distal concavity faces anteriorly, and once the tip crosses the vocal cord, we have to turn 90 degrees to the endobronchial side and advance it further till the resistance is felt, and resistance would be the carina.
Okay. Yeah. So and what mark? Usually, if the patient's height is more than 170 centimeters, roughly we can fix at 29 centimeters. But this the success rate for only blind technique is around 80 to 85%. So mostly you have to confirm further with your fiber optic bronchoscope. And before doing the FOB, you should have some bit like basic knowledge about the tracheobronchial anatomy, all those things. Okay. So how you will do the FOB? What is the method of FOB technique for insertion of the DLT?
First, we have to look into the trachea, and when we go close to the carina, we'll be able to see two lumens, that is the left and right main bronchus. As we advance further into the right main bronchus, within 1 to 2 centimeters, we'll be able to see the takeoff of the right upper lobe bronchus. And at this point, we will be able to see 3 lumens. When nowhere else in the tracheobronchial tree, this picture is seen. That is the takeoff of the right upper lobe bronchus, and the
but your patient is posted for right upper lobectomy, right? So which DLT you means choose, right one or left one?
Left side DLT.
Yeah, left side is good enough actually. So suppose if at all if you want to place the left-sided DLT by FOB, only thing is through the once the bronchial and tip it crosses the cords, like means advance your fiber optic bronchoscope through the this endobronchial tip, visualize the carina, and from that you can direct to the whichever bronch. This is left side, so you have to advance into the left-sided left mainstem bronchus, and by railroad technique you can advance your DLT. Okay. So what are the methods to confirm DLT position?
We can confirm by auscultation, sir.
Okay.
Auscultation and fiber optic bronchoscope is gold standard. We can also confirm by X-ray, chest X-ray, USG chest, and CT C-arm. Under C-arm guidance also we can check the position of.
See, fiber optic is the gold standard. Chest X-ray, all those things, it is practically not possible in the theater, right? So ultrasound, yes. Like how you. So first we'll discuss about the auscultation technique. So how like auscultation technique, how you will confirm whether the DLT is in proper position or not? This left-sided DLT.
First, after insertion of the DLT, we have to inflate the tracheal cuff first, and we have to confirm bilateral entry. And once this is confirmed, we have to clamp the tracheal lumen and inflate the bronchial lumen.
The bronchial cuff, actually, it should not be maximum. We can inflate only 3 ml. So even with the 3 ml also, if it is much more leaking, it means it is not the proper size. Yeah, it is undersized DLT. Okay. Yeah.
Then, we have to clamp the tracheal lumen and inflate the bronchial cuff with the maximum 3 ml air, and we have to confirm the endobronchial side, entry in the endobronchial side. Once this is confirmed, we have to unclamp the tracheal lumen and again confirm bilateral entry.
See, so after first, if you see here, just clamp the tracheal lumen. So you clamp the tracheal lumen. So 3 possibilities. One, it may be on the wrong side. So if it is on the wrong side, you will, instead of listening sounds on the left side, you may be hearing sounds on the right side. So 3 possibilities. Either it can be on the wrong side, or either it is too much inside, or it is too much outside. So these are the only 3 possibilities, right? So if it is too much, if it is on the wrong side, means you may be hearing sounds on the right side. If it is too much inside, means even the left upper lobe also you won't be hearing the breath sounds, because it is too much into the left lower lobe bronchus. So if it is too much outside, means what happens, the bronchial cuff will be maybe herniating into the carina, and it may be obstructing even the breath sounds on the right side also. Okay. Then unclamp the tracheal lumen and clamp the bronchial lumen. So once you clamp the bronchial lumen, now you should not hear any sounds on the left side, but you have to hear sounds on the right side. Suppose any diminished or absence of the breath sounds on the right side, it means even the bronchial cuff is herniating and is occluding the trachea. Okay, this is the auscultation technique. So coming to the with the help of the fiber optic bronchoscope, so the left-sided DLT position, ideally when you cross through the tracheal lumen, you have to see the carina. Okay, and after that, if you further advance into the right mainstem bronchus, you can see the trifoliate pattern. So this is the only segment, means like a lobe where we can see the only 3 orifices. And after that, you have to pass the bronchoscope through the bronchial lumen, and there you have to see the tracheal carina. Okay, secondary carina. Okay, means both upper and lower left lobe, upper and lower bronchus. Okay, and also here, once you pass to the carina, you can see this is the right sided. Okay, which is free, and the left side you can see the left endobronchial tube is passing through the left main bronchus. So ideally the picture should be like this. Okay. So this is the right sided, as already we discussed. So only thing is, through the Murphy size, you have to see your 3 orifices. So this is ultrasound in assessment of the DLT position. Thing is, like along with the pleural sliding sign, you have to see the seashore image. So if there is any barcode image, it means the lung is not ventilating. Okay. What are the complications of DLT insertion?
The complications include malpositioning during placement and airway trauma.
Okay. So most of the times we think like airway damage can occur with oversizing of the tube, but instead of that, actually the damage can happen more with the undersizing of the DLT. So why it happens? Because whenever you undersize the DLT, what happens? It migrates too much into the one of the segmental bronchi, and also even your tracheal lumen also, tracheal tube also, it will go into the one side bronchi, mainstem bronchi. So because of that, what happens? It can rupture the your mainstem bronchi, and along with that, here it may be ventilating only the one segment, okay, one lobe. So because of that, overinflation of this particular lobe and cause of pneumothorax can happen. Okay. So what are the indications as we discuss various type of bronchial? So what are the various indications of bronchial blockers? Especially it is very useful if the patient is having difficult airway, limited opening of the mouth, and also patient who are having tracheostomy also. Ideally, the bronchial blockers are the best for lung isolations. So what are the various bronchial blockers? Just names are enough.
Cohen and Puducherry blocker and EZ blocker, sir.
Okay. So which type of blocker is available at your hospital where you are like working? Did you see any bronchial blocker there? Okay.
No, sir, we have only DLT.
Okay. So this is the most commonly used is ARN blocker. Okay, so it has something loop at the tip. So this is like multi-port adapter. So through one port we'll be ventilating, through other port FOB is there, and we have to pass the bronchoscope through this loop, and we have to, with the help of that, we can navigate our bronchial blocker into the whatever the respective side of the bronchus. Okay. So these are different things. This is like mainly theoretical part. So this is what is univalve tube. Did you see univalve tube? And also another thing is, ideally for the passage of this bronchial blockers, ideally at least you should have some 7.5 to 8 size endotracheal tube should be, you have to intubate with 7.5 to 8 size endobronchial tube, means endotracheal tube, because your bronchial blocker is passing through the endotracheal tube only, right? So you have to ventilate, and also you have to admit the bronchoscope also while placing. Okay. So this is univalve tube. It means it has like already like it comes along with the blocker. This is like a normal single lumen tube. Along with that, coaxially this bronchial blocker is there. So once this has, while intubation, you have to pull out this up to the tip, the bronchial blocker. Then once you enter the just above the carina, with the help of the fiber optic bronchoscope, you have to like go to the respective segment, and you can block the particular side. Okay. So how you isolate the in special situations like difficult airway? Not audible.
Faheema, you are not audible. Faheema, you are not audible. Durga?
Yes, sir. In case of special conditions like difficult airway, we can use awake fiber optic bronchoscope. In difficult airways, in case of hemiglossectomy, hemimandibulectomy, or any oral CA with pharyngeal mass, we can use awake fiber optic bronchoscopy. If oral intubation is not feasible, we can try nasotracheal intubation through fiber optic bronchoscope.
See, one thing is like already anticipated difficulty while isolating the lung means definitely you can use awake intubation and you can put the blocker. Suppose unanticipated means first you can put the LNA and do the fiber optic bronchoscope and put the single lumen tube, and you can use the bronchial blocker, or you can use the video laryngoscope, and if it is possible, with the help of the tube exchanger, after intubating the single lumen tube, we can put the bronchial blocker or DLT. Okay. Suppose in case of tracheostomy, it's not like always tracheostomy means you have to put the bronchial blocker. Along with the bronchial blocker also, what you can do is sometimes we can intubate with the single lumen tube through the stoma, and through that we can put the bronchial blocker. Otherwise, you can remove the tracheostomy tube and you can intubate orally. Okay. If the area is okay, like intubate orally, and through that you can put your bronchial blocker. Okay. So what are the specific anesthetic implications in a patient coming for anterior mediastinal mass?
In case of anterior mediastinal mass, depending upon the size of the mediastinal mass, the patient can have varying degrees of airway obstruction or obstruction of the major vascular structures, like SVC syndrome, SVC or IVC. Major arteries can be compressed by the mass. And what we have to keep in mind is during the induction, if deep sedation or paralysis is used, the mass can fall over these vital structures and can cause acute airway obstruction or vascular compromise. So we have to initially secure IV lines preferentially in the lower limbs. And for intubation, we have to go for first we have to do a fiber optic bronchoscopy and find the degree of obstruction of the airway, and after that we have to intubate the patient. We have to do awake intubation of the patient either by direct laryngoscopy or ectopic guided, and we have to place the tip of the tube distal to the site of obstruction.
Okay, very good. So these are the high risk criteria for a patient who are with anterior mediastinal mass, like dyspnea and supine, in increasing cough and supine, SVC syndrome, and tracheal compression, significant tracheal compression on the CT scan. So these are the options for induction. So like as much as possible, if it is on short procedure, like some biopsy or something, avoid induction. Just that we can proceed with some local or regional. Otherwise, you have to do awake fiber optic and pass the tube, as we mentioned, like beyond the stenosis, and maintain the spontaneous ventilation with small dose of some sedation like ketamine or propofol. After that, maybe like you can do standard. Once the tube is in, you can use by standard, like you can, and give that muscle relaxant. Okay, you have to decide that. So this is like just for flow chart. So like just in short, if the patient is having low risk, so these are the high risk criteria, right? So if the patient is having only low risk, so you can use the standard IV plus or minus muscle relaxant. So if the patient is having all these high risk criteria, only option is pre-op itself. I mean, like before induction itself, we cannot induce the patient first of all, and you have to go on CPB or ECMO to maintain the oxygenation and hemodynamic stability. Then after that, you have to induce the patient. If it is possible, like most of the times what happens is, even after once the patient is on CPB, after induction also, even after the anterior mediastinal mass is removed, there is a possibility, because it's like a long-standing compression on the trachea, right? So there is a possibility even after the procedure also some amount of tracheomalacia can happen. So ideally, one or two cases what we did was, like, we'll do after induction, we'll do tracheostomy directly and we'll go ahead with the procedure. Or if it is possible, then you can.
Okay. Once the patient is on CPB and ECMO, you can induce and intubate the patient. Otherwise, if the patient is having intermediate risk factors, then like a stepwise induction, all this, like whatever the flow chart, you can go through that. Okay. Only thing is, like if you are not able to intubate, then it is okay. From upright to supine position, then spontaneous ventilation, and you can give muscle relaxant. Suppose if nothing is possible, means directly you have to go for CPB or ECMO initiation. Okay. So this is just like a management of how to manage SVC syndrome. Okay, you have to augment the preload and position the patient to the lateral side and lower extremity IV axis, and spontaneous ventilation, so that it will increase the venous return. And as soon as possible, you have to do sternotomy and lift the mask to relieve the compression. Okay. So what are the like, especially this patient will be like in the lateral positioning, right? So what are the main neurovascular injuries specific to this lateral positioning? Yeah.
During lateral positioning, the dependent region can be prone to pressure injuries of nerves. Like in the lower limbs, sciatic nerve, peroneal nerve can be compressed, and when prolonged lateral decubitus position, the dependent parts like the ear or pinna or the dependent side eye all can become edematous because of
the brachial plexus injury of the dependent arm injury is more common.
Yeah, so you have to, while positioning, you have to make sure that proper padding is done, both for the dependent and lower non-dependent arm and lower upper arms and lower limbs. And also along with that, the position also you have to see, you should take care of the eye and ear, everything. Okay, and axilla, all the nerve, means wherever there is a possibility of nerve injury, you have to take care of that. Okay. Okay. So what is the mechanism of lung injury during one lung ventilation?
During one lung ventilation, both the lungs, the lung being ventilated and also the lung being collapsed, both can be prone to injury. The main mechanisms of injury of the ventilated lung is high volume injury, that is volume trauma because of large tidal volumes, or on the other hand, low tidal volume injuries, that is athletic trauma. While using in regions of low ventilation perfusion ratios, the minimum amount of oxygen can be absorbed, leading to absorption atelectasis. And when we repeatedly use recruitment maneuvers, it can further lead to athletic trauma of that lung. And further increased perfusion of that lung can increase the capillary shear stress and damage the capillaries. And also oxidative stress can happen in the ventilated lung. Whereas in the non-ventilator or the collapsed lung, direct injury because of surgical trauma, handling of the lung can occur. And also athletic trauma because we are retreating that lung, similar to the other lung, athletic trauma can occur. And also prolonged handling can lead to release of excess cytokines, which can also communicate to the other lung, and both lungs can be injured because of cytokine storm and ischemia reperfusion injury of the collapsed lung once the ventilation and perfusion is restored to that lung.
Yeah. So this mostly, like most of the times when we are re-expanding the lung, make sure that most of the times we'll be like putting on the bag and we'll be ventilating with the bag. So that itself, it can cause a lot of injury. So ideally you have to put on the ventilator and increase the whatever the pressure up to driving pressure up to 30 centimeters H2O. Okay. So ALI can happen both in the ventilated lung and non-ventilated lung also. Most of the times the ALI is mostly to the ventilated lung because of your volume trauma or borrowed trauma. Okay. And also along with that, some inflammatory response also can happen. So what is the protective ventilation, lung ventilation strategy during OLB?
Ventilation strategies?
Ventilator strategy, we have to maintain a tidal volume of 5 to 6 ml per kg. People around
there are three areas of controversy, especially in choosing ventilation strategies in OLB. One is which mode, pressure control or volume control, or high volume or low tidal volume, and usage of P. So these three you can discuss. Okay, tell me now.
Pressure control mode will be more physiological, and patient volume trauma will be is eliminated in pressure control mode. Low tidal volume ventilation is preferred, and use of PEEP PEEP is not required in should not be used in COPD patient, whereas other patient 5 to 10 centimeter of PEEP can be applied.
Okay. So as we think like traditionally that pressure control is better, it's not like that. Either PCV or VCV can be used as long as you properly monitor changes in the airway pressure and tidal volume. Okay. It's not like pressure control is superior than volume control, but either we can use. Okay. But we have to properly monitor. And coming to the tidal volume, what is the advantage, means disadvantage of like putting the large tidal volume?
Volume trauma.
Yeah, that along with that, what happens? It causes increase in the PVR also, and because of increase in PVR, what happens? It shunts the flow towards the non-dependent, non-ventilated lung. So it increases the shunt flow, and it will further worsens the oxygenation. And also at the other end, if it is low tidal volume, what happens? It also causes atelectasis if it is not provided with adequate PEEP. So it also worsens the shunt and oxygenation. So either too much of tidal volume or low tidal volume can increase your PEEP, because what is the relationship between PVR and lung volume? If you see the graph, it is like hyperbolic. So even if at the low volumes or even if at the high volumes, like if your PVR will be high, so you have to choose the adequate PEEP. Okay, so if you see it will be like a U-shaped curve. So that's why even if the large tidal volume or low tidal volume, it increases the PVR. Okay, and it worsens the oxygenation by shunting the flow. So how low should be the tidal volume? So there is something called like 4 to 5 ml per kg is the best thing. And if you know the preoperative FEC, like tidal volume, like roughly like FRC by 8, it is a more appropriate tidal volume for the one lung ventilation. Okay. And coming to the PEEP, as you mentioned already, ideally 5 to 10 centimeters in patients with normal lung function and restrictive pattern. But in case of obstructive lung, because there is already some intrinsic PEEP will be there, so that's why ideally better to keep below 5, like so, because otherwise the total PEEP will be very high and there is a high possibility of like ALI. Okay, coming to the FiO2. So how much FiO2 is? What is the rationale behind choosing the proper FiO2?
lowest possible FiO2 to maintain a PO2 of 100 is enough for.
I mean, it's like how you will initiate the one-line ventilation then? Like initially, like how you will start and later how you will titrate the FiO2. Can you just tell me?
For pre-oxygenation, we have to start with the FiO2 of bottom, sir. And once the isolation of one-lung ventilation is initiated, we can gradually reduce the FiO2 to achieve a PaO2 of 90 to 100 millimeters of mercury.
Okay. So ideally, textbooks say like the 100% FiO2 we have to start before means after before initiation of the OLV, but this causes definitely collapse of the operative lung. But there is a possibility it can cause this high FiO2 can cause absorption atelectasis and the along with it even in the operative lung also it can cause some amount of collapse. So like theoretically like we can put like FiO2 of 0.8, and once if the desaturation is there means maybe slowly from there you can slightly increase rather than initially itself putting 100% FiO2, because there are giving 100% FiO2 itself is we are doing more harm to the patient. Okay, and also most important thing is whenever you are re-expanding the lung after procedure, always how I mentioned, like you should not ventilate with the bag. Instead of that, you have to put it on the ventilator and increase the driving pressure up to 30 centimeters H2O. And also don't expand with the 100% oxygen when you are re-expanding, because always you have to expand with the low FiO2 so that it decreases, because oxygen radicals, all those things can form, right? So it can cause oxidative stress and reperfusion injury. So that's why when we are re-inflating the lung, always use low FiO2 to prevent the reperfusion syndrome. Okay, all these things are small things, but most of the times what we do is like we'll be like taking the bag and inflating it 100% oxygen, all those things. But actually, if you see the post-operatively, most of these patients will be having that ALI. Okay, so how do you define ALI? Even though it is not a question related to this, but how you define ALI? What is the like PF ratio?
PF ratio of less than 200.
Yeah, less than 200. Okay, we are running off time, actually short of time. So and another thing is, what is how much PCO2 we can accept?
PCO2 of less than 60 millimeters of mercury will be acceptable.
So actually PCO2 up to less than 70 we can accept, provided the patient is having proper cardiovascular reserve is there. Okay, because advantages of the hypercapnia, it decreases the cytokine levels and decreases your the lung injury inflammatory response. And another thing is this hypercapnia itself, it increases your HPV response also, hypoxic pulmonary vasoconstriction response also. It increases. So and another thing is, how do you like means your EtCO2 and PaCO2 in thoracotomy, whether it will correlate?
Once the one lung ventilation is initiated, the gradient becomes wider, sir, by about 1 to 3 millimeters of mercury.
So normally, how much is the PaCO2 and PEtCO2 gradient?
Less than 2 millimeters of mercury.
Yeah, around 2 to 5 like that will be. So it will be widened during thoracotomy of the one lung ventilation. So these are just roughly like summary of ventilation strategies. So coming to the, can you just tell me like physiology of one lung ventilation, like what happens if the patient, awake patient, spontaneously breathing, not anesthetized, but in lateral position, what happens?
In an awake patient who is lying in lateral decubitus position, the dependent lung will receive more perfusion because of the effect of gravity. And regarding the ventilation, the diaphragm is still intact and it will be contracting well. So the ventilation will also be maintained in the dependent lung. So the ventilation perfusion will be matched in an awake, spontaneously breathing patient lying in a lateral decubitus position. Okay,
this is when the chest is closed. So what happens when the chest is open? The same, like spontaneous patient, spontaneously breathing, awake, non-anesthetized patient. There is some two terminology called mediastinal shift and paradoxical breathing, right? Can you just explain that?
Yes, so when the chest is open, the non-dependent side chest is open, the negative pleural pressure will be abolished in that side, and as the patient inspires, the air will come into the thorax through the open pneumothorax, and it will push the BDA stream to the opposite side. And there will be also airflow from the non-dependent lung to the dependent lung, and vice versa during expiration. So this phenomenon is referred to as pendulum phenomenon.
Yeah, very good. So how much is the total shunt? Because lot of some 6 positions are there, so there is no time to discuss all those things. But what is the total shunt during one lung ventilation?
30 to 40%.
No, 27.5%. I myself are taking the answer, but how it is? How it comes to 27.5%? So normally you can see the screen, right? So this is the non-dependent lung and dependent lung. So normally a non-dependent lung receives 40% and the dependent lung receives 60% of the cardiac output. But among that, 10% will be like overall in lateral position. This venous admixture will be there. So this 10%, if you divide in between the 2 lungs, then it becomes 35 and 55. Okay. So among this 35, again, what happens? 5% for the both lungs obligatory shunt will be there. So and 50% will be your HPV. So from 35%, if you remove 50%, it will be 17.5%. And whatever the 5% of your obligatory shunt, that is 22.5%, and 5% to the dependent lung also there will be obligatory shunt. So total it will be 27.5%. So because this is a like total shunt during one lung ventilation. So because of this, your PaO2, if you ventilate with 100%, your PaO2 will be only 150 because your total shunt will be 27.5%. So what is shunting, first of all?
Shunting is the other term for wasted perfusion. That is, perfused area will not receive adequate ventilation. So the blood will not be oxygenated.
Yeah, correct. So just briefly, what is hypoxic pulmonary vasoconstriction and factors affecting it?
Hypoxic pulmonary vasoconstriction is an autoregulatory mechanism happening in the lungs, where the small capillaries, smooth muscles of the small capillaries will contract in response to various stimuli. The strongest stimuli being PaO2.
Okay.
And when HPV is stimulated, blood will be preferentially shunted from the hypoxemic areas to the well-ventilated areas.
Okay.
The factors affecting our physiological factors and main factors PaO2. PaO2 when it falls down to around 40 millimeters of mercury, HPV is maximally stimulated. Other factors are PaCO2 and patient factors like COPD or sepsis can occur, and drug factors and the use of inhalation anesthetics, especially the older inhalation anesthetics like halothane, nitrous oxide, can abolish HPV. Newer inhalation anesthetics, when used at a MAC value of less than 1, will not have much effect on the hypoxia.
Yes. So it has, in this diagram, you can see it has a biphasic response. It will be like initially it will be 5 to 20 minutes. Later, sustained will be after 30 minutes. And if it is very less, abnormally low, like less than 40, this hypoxic pulmonary HPV won't act. Okay. And these are the factors which increase or decrease your HPV. So you can go through that. So how do you initiate one lung ventilation? Tell me.
Initiating, we have to first pre-oxygenate the patient. After induction, we have to first pre-oxygenate the patient with an FiO2 of 1 for around 5 minutes. And then we have to do we have to intubate the patient with our preferred interface of choice, like WM tube. After that, we have to
So nothing like that. So ventilate with 100% FiO2, especially for VATS. Suppose if the patient is posted for video assisted thoracoscopy, so before they put the port itself, they need complete collapse of the lung. Otherwise, the vision won't be proper. So in those cases, especially if they ask for anesthetic implications of video assisted thoracoscopy, this is a must thing. Like you have to ventilate with FiO2 of 100%. So for the denitrogenation and lung collapse. So and later, you can recruit the dependent lung also because you are using 100% FiO2, right? So it can cause atelectasis in the dependent lung also. and titrate accordingly after giving recruitment manual for the dependent lung and titrate FiO2 for as per your arterial saturation. So there is something called passive paradoxical gas exchange. Before the chest is open, so you initiated one lung ventilation. So there is something called passive paradoxical gas exchange. It is nothing but, so what happens? This is chest is still intact. It is not open, okay? And you isolated the lung. So, okay, but your W tube, it is open to atmosphere. So what happens is, during exhalation of the ventilated lung, this is ventilated lung, right? So what happens? The negative pressure will be created in the dependent lung. So this causes what happened? The sucking of the room air into your non-ventilated lung. So this is called passive paradoxical gas exchange. So because of that, what happens? Your lung won't be getting collapsed. Okay, so that's why you have to clamp when you are before the chest open itself. If you are planning to isolate the lung, you have to clamp the other lumen. Otherwise, the atmospheric room air will be sucked in, and again your nitrogenation, denitrogenation won't happen. Okay, so how you other ways to collapse the lung is, one thing is application of the negative suction for the lung to be collapsed. So you can apply the negative suction into the whatever the particular lumen, and you can collapse the lung. So what are the factors predicting hypoxia during one lung ventilation, and how you will manage the hypoxia during one lung ventilation?
The factors which are predictive of hypoxia are operating higher perfusion of the operative lung, which is found by VQ scanning, right-sided lung surgeries, and the supine positioning during surgery, and normal PFT in the preoperative period. People are prone to desaturate.
Why? Patient is having normal FEV1, why it should desaturate?
The acute loss of lung tissue.
No, what happens is patients who are having normal FEV1, what happens is they won't be having this auto peak. So what, because of the auto peak, because there is no auto peak, what happens? De-recruitment happens, completely it gets collapsed. So that's why there is a possibility of hypoxia, even if the patient is having normal FEV1, because there won't be any auto peak when compared to your COPD patients. Okay, so these are the factors which predict the hypoxia during one lung ventilation. So how do you troubleshoot hypoxia during one lung ventilation?
When desaturation occurs during one lung ventilation, if it is a severe desaturation, we have to assume to two lung ventilation and 100% FiO2, and then we have to rule out certain factors like malposition of the double lumen tube, kinking of the tube, any bronchospasm that could have occurred, any secretions or blood clot which could have blocked the airway, and low cardiac output. All of these have to be ruled out first. And if these have been ruled out, then we can guess that the desaturation is because of the shunt. So once we have come to a conclusion that it is due to a shunt, we can either reduce the shunt or we can oxygenate the shunt. So for reducing the shunt, we have to apply a CPAP to the non-dependent lung, or we have to cut off the inhalational agents or IV agents. And for oxygenating the shunt, we can assume two lung ventilation and further apply CPAP to the non-dependent lung and PEEP to the ventilated lung, or we can finally go for ECMO or cardiopulmonary bypass as a last resort.
One thing is, whenever there is hypoxemia, obviously better to ventilate two lungs, and most common thing first you have to rule out is tube malposition. So exclude the mechanical cause. So only two things can happen, because anyway after positioning in the lateral position, again you have to confirm with fiber optic before proceeding to the surgery. So two things: either the tube is too much pushed inside or came out. Okay, those two things you have to exclude. And once that is excluded, then you can do the other manuals, like you can manage your ventilated lung, you can manage your non-ventilated lung, or management of the perfusion. So these three things you have to manage once the tube malposition is excluded. Okay. So how to manage the ventilated lung? In case of ventilated lung, so there is a possibility of atelectasis in the dependent lung because of compression from the mediastinum and also the abdominal contents, and also in between whatever the high FiO2 you are using. So this can cause atelectasis in the dependent lung, and also some amount of shunt from the non-ventilated lung. So these are the factors which can cause hypoxemia. So how to tackle this is you maximize the perfusion to the ventilated lung and increase the PVR to the non-dependent lung. So how to increase the perfusion to the ventilated lung? By recruitment maneuver. So whenever you do the recruitment maneuver, automatically your PVR will become normal, because atelectasis also can increase the PVR, right? So obviously the perfusion will be increased, and also set the optimum level of PEEP. And another thing is, this is something called lung recruitment maneuver. Always when you are doing lung recruitment maneuver, don't bag squeeze. So because squeezing with the help of the bag, it can, once again you are putting on the ventilator, again de-recruitment can happen. So this is something that some protocol for lung recruitment maneuver. Either you can use PCV or VCV, and you increase the respiratory rate to 1:1 and tidal volume of respiratory rate of 10 per minute, and gradually and set the your drive at 10 to 20 centimeters H2, and at steps of 5 centimeters H2, you can slowly increase the PEEP. Your target opening pressures are 40 centimeters H2. So this is the best method to lung recruit, not like a bag squeezing, because once you change from bagging to the ventilator, again de-recruitment can happen. Okay. So how to manage the non-dependent lung? So different ways are there. One is CPAP application, and another thing is like you can, this is a suction catheter, right? So to the suction catheter, you can connect your oxygen port, and you can give it 2 liters per minute. Okay. And another thing is, this is your filter. So to the filter, to the your gas sampling port is there, no? You can connect the oxygen tubing to this also. And another thing is, as you know, like CPAP also you can apply. So there is something called, even with this also desaturation is happening, there is something, what is differential ventilation? There is something called differential ventilation. It is nothing but to the other lumen, like whatever the non-dependent, non-ventilated lung lumen is there, no? You can connect another ventilator, and you can ventilate with 60 ml tidal volume, roughly 30 to 40 breaths per minute, like small tidal volume and high breaths. So this is called differential ventilation. So one lung, the dependent lung, anyway you are ventilating with your what are the ventilated parameters which we discussed, and to the non-dependent lung you can use small tidal volume and high rate. So this is called differential ventilation. So how to manage the perfusion? By regulating the cardiac output. So once your cardiac output is increased, automatically what happens? Your mixed venous oxygen saturation also will improve, and this will have HPV in the non-dependent lung also. So it decreases the shunt. And also another thing which we can do is like temporary clamping of the pulmonary after the non-dependent lung. But inhaled nitric oxide, some textbooks they have given, but they show like there is no evidence and it is not recommended. So this is just like a flow chart for management of hypoxemia during one lung ventilation. Okay. So how do you like manage the fluids in thoracic surgery?
There's no need of third space loss during thoracic surgeries to replace the third space loss. Restrictive fluid therapy is initiated. No, an average adult should not exceed 3 liters of crystalloids per day during the postoperative period. Urine output greater than 0.5 ml per kg per hour is unnecessary.
So there are two areas of controversies, like liberal versus restrictive, because liberal, it can cause, people say like it can cause pulmonary edema. Restrictive means it can cause AKI. And also crystalloids versus colloid, but recent, whatever the studies showed that there is no need of restrictive. Okay, normovolemia is the target. Okay, restrictive causing AKI is, there is no evidence, and also there is no additional advantage of giving colloids over crystalloids. So crystalloids you can give if there is significant blood loss, means you can replace with the PRBC. Otherwise, there is no need of restrictive. Now the terminology is not gone, so there is no need of restrictive fluid regimen. Okay, you can give. But you can follow like your positive balance within 24 hours. It should be less than 1.5 liters. And in the first 24 hours, you can give up to 2 ml per kg per hour. Okay. And if the hypotension is there, instead of giving too much of volume, the hypotension may be because of your epidural and anesthesia also. So if it is a heart is means like you are adequately, if it is resuscitated, instead of that, you can use some vasopressor or inotropes to increase the pressure rather than dumping the too much of fluids. Okay. So what are the various intra-op complications during thoracic surgery? So if you see like hypoxemia, sudden severe hypotension can happen because of the surgical compression of the heart or vessels, and also remaining things like bronchospasm, arrhythmias, all those things. Hypothermia also is one of the most important things. So how do you plan for extubation of this patient?
For planning extubation, it is based upon the predicted postoperative FEV1. If it is more than 40%, we can extubate the patient on table if the patient is awake, alert, and warm. When FEV1 is between 30 to 40%, we have to look for other parameters like DLCO, VQ, ventilation perfusion, and the exercise testing. When the postoperative FEV1 is predicted to be less than 30%, we have to extubate the patient in a staged manner. But if the FEV1 is more between 20 to 30, and if there is adequate post-op analgesia like a thoracic epidural, we can think of extubating the patient if other parameters are known.
Yeah. So one thing is like, suppose if you are using univent tube, you can just withdraw the blocker because it is like inbuilt blocker. No, univent tube means, suppose if you are using bronchial blocker means you can pull out and you just retain the single lumen tube. So if it is double lumen tube, suppose if you are planning to change, so very careful. Most of the times, long time surge, long procedure, and in the lateral position, you will have lot of vocal cord edema. Sometimes it may be very difficult to again after removing the tube to pass the tube again. So there may be difficulty, like even we faced also. Sometimes it will be very difficult to intubate. So always with proper visualization only, you have to remove the DLT and you can change a single lumen tube. Otherwise, if you are not able to change, means even what we can do is DLT. You can just pull the tip of the bronchial lumen above the carina also. That also you can do. But ideally, if it is possible, better to change to the single lumen tube. Okay. So what are the various methods of pain management in thoracic surgery?
For pain management, we can either go for systemic medications or nerve blocks. In systemic medications, we have opioids, NSAIDs, gabapentinoids, dexmedetomidine, clonidine, etc. And in nerve blocks, the gold standard is said to be thoracic epidural. And other options are intercostal nerve block, paravertebral block, serratus anterior block, or cryoanesthesia can also be used, and also intrapleural catheters can be used.
Yeah, very good. The recent latest blocks are like a serratus anterior and even the erectospinal plane block also. You can divide into regional anesthesia techniques and your systemic therapies. Okay. So what is ERAS?
Enhanced recovery after surgery protocols.
Okay. So there are some guidelines even for thoracic surgery also, like especially for the intraoperative phase, if you see, better to use minimally invasive and short-acting anesthetics, protective lung ventilation strategies, and use of thoracic epidural analgesia. So with all these things, like we can recover the patient soon. So that is called like your enhanced recovery specifically for your thoracic surgery. So these are some of the level of recommendations for each thing. Like all these things which are just you can go through that multimodal analgesia, all short-acting anesthetic agents, lung protective strategy. The evidence is very strong. Okay. So the recommendations and evidence is very strong. So you can just go through that. Thank you.
Thank you, Sudheer sir and Jaya madam. It was an excellent session. So we are coming to the conclusion part of this thing. So for the postgraduate shake, actually, we have discussed about presentation in respiratory system. But because of the time factor, we couldn't cover up other things like, say, we have to concentrate on COPD and anesthesia related issues like patients coming for critical care when the patient is having similar presentation, coming with respiratory distress, landing up in critical care, or patient posted for emergency surgeries.
So Jeyaprakash sir, you can put the questions in the chat box to the examiners. Gurusanthiya. So I will put the questions to the examiners. Sir, you can put the questions in the chat box to the examiners.
Oh, okay, sir. Okay, sir. And the final tips by Dr. Edward Johnson.
Discussions are questions, question discussions. Questions in the chat.
Okay. Chat box questions, yes. There are some questions in the chat box, like, and some has been answered. For Sudheer sir, recruitment maneuver using ventilator.
Yes, sir. Recruitment maneuver means like especially for the ventilated lung. So ideally, because that itself can cause barotrauma, right? So better in a graded manner. Actually, like even in the ICU also we use from the ICU ventilator. Like so, if we are using pressure control ventilation, so set at some 15 to 20 centimeters H2O2, and respiratory rate, because you need to have proper spacing for each breath, right? So you have to come down on the respiratory rate to 10 per minute, and IE ratio also 1:1, and from that you gradually increase PEEP, like every 30 seconds, like every 4 centimeters H2O, up to 20 you can go. But at the same time, you have to monitor the peak pressures also. It should not go beyond 40 centimeters. You have to set the alarm like that. And then once you achieve that, then slowly come down. Okay, and set at the optimum peak, like maybe around 10 or something, depending on the compliance of the lung. So this is the optimum, like ideal method for the lung recruitment. Even you can do with the help of the volume control ventilation also. Volume control ventilation, the peak will be like set at 10 or something, but the tidal volume at a rate of 4 ml per kg, slowly increase the tidal volume. But you have to keep the target of the inspiratory, means like your peak pressures also. It should not go beyond 35 or 40. So ideally, pressure control ventilation, both can be used, but with the help of pressure control ventilation, it is the best, means better to recruit the lung. It is not suggested to like ventilate with the bag and then putting on the ventilator again. So during this process, again, there is a possibility of de-recruitment. That's what usually we do.
Sir, how to identify auto-PEEP intraoperatively, and how to treat it or prevent that?
Auto-PEEP, suppose if you have that your spirometry, because most of our anesthesia ventilators nowadays we have spirometry, right? So you can, like at the ending expiration, if you pass that, you can see actually auto-PEEP. If you have that spirometry in the anesthesia ventilator, means like in the operative, means inside the ward, that we can definitely see your auto-PEEP.
Jaya, your comments about that CPAP valve, something they asked for.
Yeah, they asked for it, non-dependent lung, how to give CPAP.
Yeah. Somebody has put that. You want to repeat?
I just answered. We can use the CPAP valve to give non-dependent lung CPAP, to give CPAP to non-dependent lung. Or if you can use, like Sir told, suction catheter can be attached and give 2 liters per minute. And either we can use brain circuit or JRMFT also, we can use to give CPAP, but we have to make sure that the lung is not overinflated. Because we can't control it.
One more thing is, sir, like already the lung is collapsed completely, and during hypoxemia only you will be introducing this oxygen, means like giving oxygen, connecting the oxygen line to the non-dependent lung. But already it won't be that much effective, provided, because already the lung is atelectasis. Like to open up that collapsed lung, at least it needs some amount of driving pressure. So initially you have to ventilate with at least 20 centimeters H2O2. Then the lung will be opened up. So, but it will be for some time it will be affecting your field. But just if you give the oxygen flow to the collapsed lung, it won't be effective. So you have to open up the lung. For that atelectatic lung to open up, you have to give some amount of recruitment. Then you connect your oxygen. Then it will be definitely effective.
Sir, there is one question on how to change the tidal volume from when we convert from 2-lung ventilation to 1-lung ventilation.
So ideally, like 5 to 6 ml, like roughly 5 ml, we can give. But theoretically, somewhere I read like by FRC by 8, if you give, means that is the total tidal volume. That's what it is mentioned in the textbook. But one thing students should like definitely like a take home message, like If the saturation is low, means most of the times I have seen like the residents like increasing the tidal volume, giving almost like whatever the like 400 ml to the single lung. They think that usually it may improve the oxygenation, so that it should not be done. Okay, actually, best thing is low tidal volume around 3 to 5 ml per kg. Along with that, optimum PEEP should be applied. Suppose if you are giving only low tidal volume without PEEP, means you are further worsening the situation, because your PVR will further go up and it will increase the shunt and further worsens the oxygenation. And another thing is, all these things, it is okay, but each case is different. So it is like one lung is ventilation is sometimes, if it goes well, means it is fine, but sometimes you have to like really sweat a lot. So it is not that easy, like theoretically what we are speaking. But yeah, lung isolation, sometimes if it gets hypoxemia or a tube dislodgement, all those things are like, it's not so easy as we discussed theoretically, actually, unless you really experience, and each case is different. That is my understanding.
Sure, no other questions, I think, right? All questions are covered. Huh?
Yes, sir.
One more question to you, Sudheer sir.
Oh.
How to give CPAP through blockers? Is there any way you?
Actually, CPAP through the blockers, we are not giving, but thing is like that once the opening port of the blocker is there, right? So actually that we can use for suctioning also. To that also, actually we can do give suction. And some people say like, because with the help of the blocker, if we are able to only some segment of the lung, if you are able to block, to the other segment, like bronchoscopic guided oxygen insufflation we can do. But how much practically it is possible, we don't know. But the opening port will be there, no? The tip of the blocker, actually we can actually insufflate some oxygen actually.
As Sudhir said, without opening the alveoli, insufflating the oxygen in the non-dependent lung is not going to help through anything anyway. So the already alveoli collapsed, you are insufflating the oxygen, it is not going to give any advantage. So as you said, we have to ventilate the alveoli, open up the alveoli, then give the oxygen supplementation. That
then it will be effective, sir. Yeah.
Right. So what is that?
Hello, sir. So we are done with the questions, sir.
Okay. Okay, sir.
So the final conclusion part we can proceed with, sir.
Okay. Thank you, Rajesh, for wonderfully conducting this discussion. Thank you, the examiners Sudhir and Jaya, almost covering all the questions. We are expected, the students are expected to get in the exams. Thank you. So concluding this discussion, I will present some. This is my share. I will share. It is a concluding message only. So for a respiratory system, we will get two type of cases. One is COPD case coming for any other surgeries, and bronchiectasis lung abscess patients coming for pneumonectomy is the two type of cases you will get from the long cases in the examination. I am just consolidating what you have to concentrate. So you have to concentrate on the definition of the COPD. So you prepare a notes for yourself. So what are the probable questions they will ask in the examination, and prepare answers for that. Then only you can present in the examination in a continuous flow without any interruption. So we must know the pathologies of COPD. Then you must know the differential diagnosis between the bronchitis, emphysema, bronchitis between the asthma. So they may ask the difference between the COPD cases. Then you must know the guidelines and for the diagnosis and assessment of COPD. There is NICE guidelines is there and GOLD guidelines is there. You have to read that. Then other investigation, they have clearly discussed the bedside pulmonary function test, spirometry, PFT. So they may ask you to draw the diagram of the spirometry in the examination for restrictive lung disease, for obstructive lung disease. So be prepared for that also. Then the treatment aspect, already they have discussed. Then the preoperative evaluation, JIPMER has nicely correlated the history with the diagnosis, physical examination and the diagnosis. So what are the lab investigation you have to? So you have to present it in a fluid manner without any hesitation. So, but you concentrate the investigations which are done in your hospital, you should say. You should not say the investigation which are not routinely done in your hospitals. So we prepare for that. And also assessment of the risk of pulmonary complications. There are so many risk factors are there. Non-Mullins criteria, cardiopulmonary risk index, and Lawrence risk index, Brooks-Brunn risk index, then the Arazula risk index and Ariscott risk index. So there are so many risk index. You please go through the risk index. It is given in the journals. Some textbooks they have mentioned, but it is available in the journals only. Then your preoperative intervention. So smoking is more important. So you must know the effect of smoking on the respiratory system and the effect of cessation of smoking on the respiratory system. Both of them you have to thoroughly know with time interval. Then the perioperative steroids, they are discussed in this discussion. Suppose the patient is taking steroids in the preoperative period, how will going to supplement the steroids in the intraoperative period? That is also more important. That is the usual question they will ask in the examination. Then anesthetic and surgical factors affecting the pulmonary function. They have all discussed everything in this discussion. That is airway manipulation. So what is the role of airway stimulation with endotracheal tubes? How to avoid that, and how to can it be used LMA? So these are the questions. So what are the advantages of general anesthesia, regional anesthesia, and the site of infection, that is surgery, and position during the surgery, and duration of surgery? Will they affect the outcome of the patients? So this they will ask. Then what is the advantage of open and closed laparoscopic procedures? Then intraoperative complications, they all discussed. So these are the things you have to prepare yourself before going to the exam. So for that, you have to, so coming to the bronchiectasis cases for lung abscess, this is a pneumonectomy case. Similarly, the etiopathogenesis, your definition, preoperative preparation, and your intraoperative complications, separation of the, when you are going to tell about the separation of the lung isolation, what are the things you are doing in your institution? You tell them. The PG told that we are not using the bronchial blockers in our institution. So that should be the answer. We use which type of lung separation in your institution? You have to answer. Likewise, then coming to the textbooks, you have to follow. So these are the textbooks you have to follow. For the first years from itself, you start reading from Stolting, Pharmacology, Physiology, Coexisting Disease, Miller's. The wonderful book available for the one-lung ventilation for COPD patient and thoracic surgery is Anesthesia for Thoracic Surgery by Benumov. All of you know Benumov has written Airway Management, but this book is very wonderful book. Most of the chapters written in the Miller's are from this book only, Anesthesia for Thoracic Surgery. So everybody has to read this Anesthesia for Thoracic Surgery in the first year and second year itself. If you are in the final year, then you can go for the notes. So these are my notes available on this subject. So 5 notes I have written, almost covered all the possible questions in the examinations. And also coming to the theory, you have to read all these books from the, it is not possible to read in the final year exam. You have to start reading from the first year itself. So Egan's, Nunn's are the wonderful physiology books you have to read. And when you come to the second year, third year, you have to read the anesthesia thoracic surgery books. So my notes are also available for the theory part, but it is not complete. So I will give the tips for the examination. When as an examiner, when I go for an exam, I used to see 3 types of PGs. One PG is he will be more tensed, more stressed, and he will not answer even though he know the answer. He will not be expressible in the examination. So that is one type of PGs. The second type of PGs, they are cool. They will answer to the question, even though they know more than the question, they will not answer more than the question. They will answer only to the questions. So there are second type of PGs. Then there are third type of PGs. When you put a question, they will tell you all the things he knows without bothering about the question. He will tell all the answers. So do you know which PG will get the high mark? It is the second PG, who answer only to the questions. So in the examination, don't try to be smart and answer whatever you know. So you try to answer the questions, particular questions, the answer to the questions. That's all. If you know more than that, let the examiner to ask the more questions and let them know you know more than that. So we as examiners, we give more marks to the second type of PGs, not even to the smart PGs. So smart PGs, they know, they try to impress the examiner with their knowledge. Don't do that, or don't overreact in the exam. You answer to the question. So this is the best way to face the examination. Be bold, be cool, be calm, don't be stressed. You answer directly to the questions. So give a space for the examiner to lead another question. So the examiners want to ask more questions. So give them a space to ask more questions, then answer. Don't jump onto the answers for the next questions. Don't expect he will ask this question and I have to answer now itself. Don't do that, overreact. Be calm, be patient, and be cool, be bold. So that is my tips as an examiner to the exam going pages. So with that, Gurusanthiya, you can give some tips how to write the theory classes. Theory. So I will stop sharing. Gurusanthiya, are you there? Yes. Please go on. Gurusanthiya, you are not audible. Gurusanthiya, you are not audible. Gurusanthiya, you unmute yourself. So next week onwards, we are going to start discussion on the cardiovascular system.
Sir, am I audible now?
Yes, now audible.
Yes. So today I'll be covering about the theory questions which may possibly you may get in the examination and how to cover it about. So in the previous sessions, we have seen about all these in details, and this is just a gist of all those so that you can look for the in the exam the questions and then find a way to answer it. So if at all these questions I have compiled from the last 10 years question from the MD question paper. So if you are asked about an oxygen cascade, whenever you are asked about a question, wherever possible, you have to draw the diagram and explain to the examiner that you have known the answer for. So if you are asked about oxygen cascade, you have to possibly draw this diagram and say it starts from the atmosphere and then down to the mitochondria, and then it again when it comes to the alveoli, what happens. So if you are asked about oxygen cascade, you will tell about what are the factors which affects the oxygen level at this level and at the alveoli level and at the mitochondrial level. So you are supposed to describe this diagram as a whole and the factors influencing for discussing about the oxygen cascade. The next possible question is the alveolar gas equation. In the alveolar gas equation, you are supposed to write about what is the alveolar gas equation, what it is used for, and how do you calculate the pulmonary alveolar oxygen tension from the normal values, and what are the factors which can affect the alveolar oxygen concentration. And you have to discuss everything in detail about all these parameters which are discussed by Dr. Edward sir in the previous session. So if it is an oxyhemoglobin dissociation curve which is asked, you have to describe this curve, say why it is sigmoidal and what is the significance of the steep portion of the curve or the flatter portion of the curve. What is the relationship between the PaO2 and the SpO2 ratio? What are the conditions in which it is shifted to left and what are the conditions in which it is shifted to right? Tell them about the Bohr effect, Haldane effect, and the importance of this in the clinical practice. These are the points you have to cover when you you are actually writing on oxygen dissociation curve. So when it comes, there is another question on carbon dioxide dissociation curve or carbon dioxide transport. There is an excellent article by Dr. Bhavani Shankar Kodali and also notes from Dr. J.Edward sir. You can go through it for further detail for writing up in the theory examinations. You are supposed to write about, you are supposed to draw this carbon dioxide dissociation curve and say that it is more steep than the oxide dissociation curve. What is the relationship between the PaO2 and PaCO2 and the arterial content or the venous content of carbon dioxide? You have to say them about what are all the mechanisms by which carbon dioxide is transported. Here you have to also draw the diagram and saying the chloride shift which can happen in the tissue side and also how it is exchanged at the lungs. The next possible question which was asked is oxygen extraction ratio. Whenever a question is asked, whenever there is an available definition, you have to write the available definition and write about the oxygen extraction ratio. And how it is derived, the formula you have to write, and what are all the factors affecting each component of the particular factor, you have to write about it. Then you say like what are the factors which are affecting the arterial oxygen saturation. You have to point about cardiac output, hemoglobin and the SaO2 which can probably affect the oxygen extraction ratio. You have to say what is the normal extraction ratio for, what are all the importance of increased oxygen extraction ratio. Draw this diagram whenever feasible and tell them when the oxygen ratio extraction ratio is going to be higher than the lactate mechanism and the anaerobic point where it can occur, and how do you want to maintain the DO2 and the extraction ratio in a critically ill patient is what you have to discuss in a patient in a question in which oxygen extraction ratio is asked. So most of the question papers have concentrated on pulmonary function test, mainly bedside pulmonary function test, or asked about preoperative evaluation of a patient who can come for a one lung ventilation or a pneumonectomy. So you tell them about the bedside pulmonary function test, what are the tests for vital capacity, what are all the tests for vital capacity and dynamic function, and what are all other bedside available pulmonary function tests like ABG, respiratory rate and all that which has been discussed in the previous session. You tell whatever it is asked, you tell them the indication and contraindication for a bedside pulmonary function test or a spirometry which is asked. When you also concentrate on differentiating them into, do not crowd them and write it. You always differentiate them into the tests which are looking for the lung function, the test which looks for the parenchymal function, and the test which look for the cardiopulmonary interaction. So whenever you are asked about lung volumes and capacities, there are two probable questions. One is functional residual capacity and one is vital capacity. So whenever FRC is asked, you draw the Pappenheimer's curve for the lung volumes and capacities and explain them what is FRC. FRC is ERV plus RV, that is the amount of air that is remaining in the lungs after normal tidal respiration. You say the normal value. You say the importance of changes in the anesthesia, like if you are making the patient supine, if you are inducing the patient, if you are paralyzing the patient, what is the effect of all those on FRC and oxygenation. You say what is the physiological role of FRC in oxygenation and PVR, and also what are the changes which can happen in a pediatric patient, pregnancy and an elderly in relation to FRC. And you tell them about the FRC and closing capacity relationship which were discussed in the previous lecture. If again vital capacity is asked, you draw the same curve and tell them what is the normal value, what are all the changes in anesthesia, pregnancy and positional changes in anesthesia. One thing to notice, vital capacity is decreased to the maximum in lithotomy position of around 18%. We have to write about all those changes which can happen in anesthesia and which can impart an effect in the perioperative period. So another question is peak expiratory flow rate. You draw the diagram which I have shown in the previous lecture for the peak expiratory flow rate using the flow volume loop curve. You tell them what is PEFR, how it is measured, either during a spirometry or a Debenhams whistle or a peak expiratory flow rate. You tell them it is effort dependent. Whenever they ask about FEE 25 to 75%, you tell them it is effort independent and it is based on a smaller airways. Depending upon the question, you tell them which part of the curve it is going to occupy and which part of of the airway does it signify? Always write gender-based values for all the lung volumes and capacities which are asked, and you always draw flow volume loop curve or a volume time curve for denoting whatever it has asked. And the importance of anesthesia is if it is going to be less than 200 liters per minute, then they are going to have an inadequate cough and also land up in postoperative pulmonary complication. They have asked about flow volume loops. Any flow volume loop which is asked, may it be an intrathoracic obstruction or an extrathoracic obstruction. You first describe a normal loop. You tell them what is inspiration, what is expiration, and then you draw the particular loop and explain them what is happening. If it is a fixed upper airway obstruction, you tell them why both inspiration and expiration is affected and why the box loop has come. Another question which was asked is the transfer factor or DLCO. This also was discussed extensively in the previous lecture. Whenever something is asked, you tell them what is it, why it is done for, what is the test gas used, what is the normal value, what are all the factors affecting. The point you have to write extra is how it is useful in the preoperative evaluation of lung resection and also how it predicts the postoperative morbidity and mortality in such cases. They will ask you about how to differentiate between the obstructive disorder and the restrictive disorder. This also was explained in detail. You please go through the previous lecture and find out how these are made and write it elaborately to the point. And lung resection surgeries, I hope Dr. Edwards has just now covered it. Whenever you are asked about a long note about lung volume resection surgery, you write about the preoperative assessment, three-legged stools, how will you prepare, methods of lung isolation, as we have extensively discussed now, like the realities, bronchial blockers. You draw images wherever necessary to tell them to have known, and also that can fetch you more marks in the theory examination than writing some pages and pages of theories. And you also have to write about why hypoxia occurs and how hypoxia is counteracted by the body's normal physiology, and V by Q mismatch in the dependent and the non-dependent lung, and how this has been extensively discussed in detail. Thank you. These were the possible questions which were asked in the previous 10 years question paper for MDs and DNBs in the respiratory system alone. Thank you.
Thank you, Gurusanthiya. Now I know how you got the best outgoing from Madurai. You know the tricks of writing the theory exams. Thank you, Gurusanthiya. Thank you, Rajesh sir. Thank you, all the participants. And thank you, the examiners today, Jaya and Dr. Sudheer. So we will meet the next week. So I thank the A1 Logic Shilpa. Thank you very much. Shilpa, thank you very much. We can wind up this session. Thank you. Thank you, Ananda.
Thank you.
Thank you.